original topic given to me was pathogenesis of retraction pockets, but I decided to add on some flesh so that some management aspects, so that for our learning will be made complete sort of. So retraction pockets they consist of invagination into the middle ear space of part of the tympanic membrane. And these are said to some are fixed when it's adherent to the structures in the middle ear, or it may be free, such that when you do pneumatic otoscopy, you might be able to displace it medially and laterally off the middle ear. So the retraction pocket theory was first described by Bezold in 1890. And he described the pathogenesis of cholesteatoma as being part of a retraction due to the retraction of the pars flaccida or the posterior superior part of the pars tensa or the entire pars tensa. So retraction pockets tend to be commoner in children from the research articles I read. And the danger of these pockets lies in their ability to cause ossicular chain erosion, cochlear cholesteatoma formation, and then potentially causing complications of cholesteatoma, like labyrinthitis, mastoiditis, the facial nerve palsy, and then intracranial complications as well. And many unknown factors influence the development of these pockets. It's said that the normal tympanic membrane is tough and elastic, but the retraction pocket area is flexible and collapses into the tympanic cavity. The places of weakness have been found mainly to be at the notch of Ravenous, the scutum, and on the malleus. So the notch of Ravenous is defined as the area that lacks the fibrous annulus superior to the malleus. And then around the malleus is also another potential point. And then on the scutum, which is the bony spur, a sharp bony spur that is formed by the superior wall of the external canal and the lateral wall of the tympanic cavity. So these tend to be areas where retraction pockets tend to start from. Epidemiological studies have shown that these, I've mentioned this already, that they tend to happen in children more often. Another study said that 294 children who were aged between 5 to 16 were examined and found that the retraction pockets were found in 26% of the participants. It was found in the pars flaccida, whilst 3.7 was in the pars tensa. This tends to be the normal finding, but I came across other texts that said otherwise. I don't know. Maybe at the end, Prof, you can give your input.
Quick question on that, Peter. Sorry to interrupt you, but oh, you're about to talk about it. Okay, never mind. We could. I don't want to interrupt you too much. We'll come back to it.
Yes, please. So the structure of the tympanic membrane consists of three layers. The external epithelial layer, which is stratified keratinizing epithelium, which is in continuity with the epithelium of the external auditory canal. And then there's the middle layer, which is also called the lamina propria, formed by connective tissue with predominance of collagen fibers types 2 and 4 arranged in 2 layers. So there's an outer radial and inner circular layer of these collagen fibers in the pars tensa. And also there are elastic fibers and delicate vascular and nerve plexus. The lamina propria of the pars flaccida, unlike that for the pars tensa, which is well organized, is loosely arranged with elastic collagen fibers, the type 1. Then there's the internal mucosal layer composed of simple cuboidal epithelium, which is also continuous with the middle ear cavity mucosa. Other texts describe it as columnar epithelium, and its function is to provide protection, metabolism, and nutrition of the middle layer of the tympanic membrane. So the structure, a cross-section of it looks like this, where we have the epidermal layer, epithelium, which is in continuity with the external canal, and then the lamina propria, where you have the radial and sepal collagen fibers. And then there's the mucosal epithelium, which is in continuity with the mucosa of the middle ear. So various classifications have been made of to describe the retraction pockets. The commonest and most widely used ones are the SADE for the pars tensa, the TOS for pars flaccida retraction pockets, and Caracon. So these systems grade the severity of retraction pockets, but their downside is that they do not explain the pathogenesis or possibility of progression of retraction pockets. They also fail to guide treatment. So the SADE.
Could I ask a quick question, Peter? I'm sorry.
Yes, Prof.
And I'll throw that out to any of you guys. Maybe I'll ask your colleagues because you're giving the talk, but why do they call it pars tensa and why pars flaccida? What are the differences between those two areas? Because fundamentally, the difference does place a propensity for where these retraction pockets will form, as you've mentioned. But what is the fundamental difference there between those two?
The pars tensa so we spoke about the 3 layers. Those 3 layers actually describe the pars tensa, because the pars flaccida doesn't contain the collagenous or fibrous middle layer, and that's why it's more loosely around, and that's why the retraction pockets tend to happen in the attic, which is where the pars flaccida is.
Exactly right. You got it. Exactly. And so keep in mind, sorry, Peter, just one more quick point, and is the term chronic otitis media, we've talked about this before. Remember, chronic otitis media portends any permanent defect in the drum that's beyond a 3-month period. That defect could be a hole in the drum, it could be a retraction pocket, etc. So it's really important, and Peter mentioned this, is to do pneumatic otoscopy, because you're trying to determine between if it's adhesive, if that underlying mucosal layer has stuck to the underlying structures, or is it atelectatic, meaning it's very just thinned, but it's still mobile and not stuck down. So when you're looking at an ear in the clinic and you do a really good binocular microscopy exam, you want to look at all the quadrants of the drum, look at all the aspects of the drum, clean the ear as best you can. If there's crusts or debris, clean that away so you can actually see the drum. And then when you do pneumatic otoscopy, it'll tell you, it's almost like it adds more adjectives to the description of the chronic otitis media. Is it chronic adhesive otitis media with suppuration and cholesteatoma? So you can see how you can add all these different qualifiers to it. But really important to get used to referring to these ears that way, and then describing if it is chronic otitis media. Is it adhesive? Is it atelectatic? Is there suppuration? Is it infected? Is there cholesteatoma? Those types of things. So yeah, good. Sorry, Peter.
No problem. It's all part of the process. Thank you. So the classification for the pars tensa retraction pockets, so the grade 1, if this is the normal tympanic membrane, then a slight retraction of the pars tensa will be grade 1. Then grade 2 will be where the retraction is onto the long process of the incus. And then grade 3 is onto the promontory. And then grade 4 is when it is onto the promontory but is adherent. So that's where we'll have the atelectatic and then the adhesive type of retraction pockets, or the yes, the retraction pocket. Then the grade 5 is where you have a perforation in the tympanic membrane. So I found these pictures in Scott Brown. So where there's the retraction, initial slight retraction, that will be the grade 1. Where it's onto the long process of the incus, then we'll be talking about grade 2. Then where it is plastered onto the promontory will be the grade 3. Then grade 4 is where it is really adherent, and this is the Marengo's staphylopetesis stage, where it's so it is the dripping all the ossicles as well as the promontory. And then the grade 5, where you can have what looks like a perforation in the tympanic membrane having been retracted completely. Then the TOS. So for the TOS, the normal pars flaccida will look somewhat like this. The type 1 is where the retraction pocket is towards the neck of the malleus, but then there's a space between the malleus and the pars flaccida. Then when it is attached to the neck of the malleus, that will be the type 2. The type 3 is when the bony rim or the annulus is becoming eroded to some extent. Then that will be the type 3. Then type 4 is where you have a definite erosion of bone of the annulus. That will be the type 4. Again, these are pictures from Scott Brown. So a slight retraction in the attic, then onto the neck of the malleus, then where there's some resorption of bone, and then where you can completely see the stage 4, where there's a complete erosion of the bone and the scriptum might also be eroded. So that will be the grade 4 of the TOS. The Caracon, I couldn't really get pictures for that staging, but at least I got this table which says that the stage 1 is where there's a mobile retraction pocket, mobile on pneumatic otoscopy. Then grade 2 is where it's fixed, the fundus is visible, so you can see into the end of the retraction pocket. Then the type 3 is where the fundus is not visible. You can't see all the way to the end of it. So these are theories or explanations for how the pathogenesis of retraction pockets occur. It said that long-term negative pressure in the middle ear is the main thing, or is one of them. Normal tympanic membrane, as we've said already, is tough and elastic, and that's able to withstand the pressure changes. Then ears which have anomalies in the volume and ventilation of the epitympanum are more susceptible to retraction pockets. I'll talk about this point again. But pathologies that tend to cause eustachian tube dysfunction include some congenital malformations like cleft palate, where there's a problem with the anchorage of the tensor belli palatini. So the opening of a eustachian tube is not good. So it tends to cause eustachian tube dysfunction. Then you can have mucosal edema, adenoid hypertrophy. And so these are factors which can affect the equalization of pressure between the middle ear and the nasopharynx. So some of the factors that can cause the mucosal edema are atopy and allergic rhinitis, nasopharyngeal infections, and gastropharyngeal reflux or gastroesophageal reflux. This was a study that was done, one of my references, and it showed evidence of pepsin and Helicobacter pylori in the middle ear fluid of children with otitis media, to mean that this is one of the issues that contributes to the otitis media in children and also causes retraction pockets. We know that in children, the eustachian tube is more horizontal, is wider, and is shorter. So issues in the nose or in the pharynx or fluids in there can easily cause problems in the middle here. In fact, but it's been found that some children after adenoidectomy or ventilation tube insertion still develop retraction pockets or cholesteatoma. So retraction pockets can occur even in the absence of negative pressure in the middle ear. So even whilst they have the ventilation tube, they still develop retraction pockets. Plus, from some studies, it's been found that negative middle ear pressure alone may not be sufficient to cause the retraction pocket. So otitis media is one of those issues that contributes to the formation of retraction pockets. I mentioned this already, that children with recurrent otitis media or otitis media with effusion tend to have the retraction pockets. And sadly described that inflammation is responsible for the degeneration of the lamina propria of the tympanic membrane. And some experiments have shown that the initial reason for the development of cholesteatoma from the retraction pocket is local inflammation of the mucosa of the middle ear. So some common middle ear pathogens increase pro-inflammatory cytokines in monocytes, contributing to it. And in 2018, Hartenberg published the self-healing hypothesis as the starting point of a retraction pocket. And this idea interprets the horizontal migration of skin into the middle ear as a self-healing process. And that is also something that is said to contribute to the formation of retraction pockets. Inflammation in the pathogenesis of retraction pockets. So generally, it said that subepithelial inflammation infiltrates are found in 86% of patients. Then this is from the study, below. The disruption of the double layer of collagen fibers and its infiltration by neutral mucous substances in 87% of patients with retraction pockets. And they also found that fragmented elastic fibers were in 96% of patients, all to show that retraction pockets don't just form from negative middle ear pressure, but inflammation or otitis media contribute to it. Then this factor, I'm hoping that after my talk we'll discuss it further, but air diffusion in the temporal pneumatic system is regulated by what is described is called the tympanic isthmus. And the tympanic isthmus boundaries are the tensor tympani anteriorly, the posterior impedal ligament posteriorly, the incus and the head of the malleus laterally, and then the attic medially. And the tympanic isthmus is the main ventilation pathway of the epitympanum through its diaphragm. And the eustachian tube ventilates only the mesotympanic and hypotympanic spaces. So to mean that the main ventilation for the epitympanum is through the tympanic isthmus. Where there's a blockage of the tympanic isthmus, gas exchanges only occur in the mastoid cells. And it's been found that people with partial pneumatization or sclerosis of the mastoid and inflammation of the mucosa, they have a hampered middle ear ventilation, and it leads to a negative pressure. And that abnormal gas exchange in the middle ear associated with the compromised buffer from the mastoid bone contributes to retraction pocket formation. I came across an article that talked about Boyle's law, and the way they explained it, I couldn't really apply it well, but I thought I should bring it up so that maybe Prof will clarify it first. He said that pressure at a given temperature, pressure, the product of pressure and volume is a constant. So to mean that if you have a limited volume of the epitympanium and the mastoid because of sclerosis and inflammation, it should run. So from the text I read, they said if you have a smaller volume, then the pressure becomes more negative. But it didn't make sense to me because if the product is supposed to be constant, then if you reduce the volume, it should rather be that the pressure increases and so. So I couldn't really understand it. Maybe Prof will understand it better. You can explain it to us. But the point is that the pneumatic system of the epitympanium, once it's hampered, it encourages the formation of retraction pockets. So in the diagnosis, we will have to make sure we have examined well. Otoscopic, we'll do microscopic examination. If we have to use endoscopes, get to see the ear canal in the tympanic membrane well, clean out any debris, and then have a good appreciation of what the retraction pocket, or if there's a retraction pocket, what it contains, or if it doesn't contain anything. We have to do the audiometry to get an idea of the hearing loss, because if there's a retraction pocket which doesn't look suspicious, but there's a hearing loss, a significant hearing loss, then it's possible that beyond what you are seeing, there's something else in the middle ear. We need to do a tympanometry. It gives us an idea of the function of the middle ear and the state of it. Then radiological examinations like the temporal bone high resolution CT is important for surgical planning to evaluate the state of the ossicular chain and to rule out presence of polysteatoma. And then doing a video rhinopharyngoscopy is also useful to evaluate the eustachian tube, whether there's the openings, whether there's adenoid hypertrophy, which is initiating all this, or a nasopharyngeal tumor or something like that. One of our consultants has been insisting that when we see a patient with otitis media in an adult, we should always exclude something in the nasopharynx in our workup. Dr. White. Ultimately, so in the management, ultimately the decision is guided by a balance of the potential benefits, the risk of the interventions, and taking into consideration the patient's underlying baseline state. So different modalities may be employed. Watch and wait is one, where we'll just be observing what happens to that, the retraction pocket we've seen. We could have the patient coming in every now and then to have examination done. Then the medical management and surgical management. So for the medical management, again, more like initially looking like, well, we'll have regular inspections or micro otoscopies done. We'll regularly toilet the ear. If we need to improve the nasal and eustachian tube function with decongestants, antihistamines, and steroid sprays, we do that. And then Valsalva maneuvers and inflation devices for the eustachian tube dysfunction is also useful. So beyond this will be surgical management, and the choice again depends on the underlying condition and the extent of the disease. So the main goals would be to improve middle ear ventilation and repair the retraction pocket itself. So for improvement of the middle ear ventilation, we can employ the eustachian tube dilatation methods, insertion of ventilation tubes, grommets or T-tubes, adenoidectomy for patients with persistent adenoidal hypertrophy. what I want Prof to clarify for us will be whether if you have a situation where a patient develops a retraction pocket and in your treatment you remove adhesions or the head of the malleus, would that contribute to improving the middle ear ventilation? That I didn't really find text, but I thought I had seen from the service I had seen, I was wondering whether it would make a difference. So retraction pockets without cholesteatoma, we can do the excision of the retraction pockets and then we add on tympanoplasty. So this might be medial or lateral fascial grafts or cartilage reinforcement tympanoplasties may be done. The ones which have cholesteatoma, again, it depends on the extent of the disease, the structures involved, and the patient's hearing. Considering the material used for reconstruction of the tympanic membrane, many studies demonstrate that there's no statistical difference in the outcome by using a graft of the temporalis fascia or a cartilage graft. Again, Prof, please at the end, you tell us what you have experienced. Then the graft, cartilage graft is preferred for its intrinsic strength, which is greater than the one, those done with the temporalis fascia, and for its higher mechanical stability and the negative pressure changes. I also read that in as much as the cartilage graft is good, the problem with it is that it also hampers the pneumatization or the aeration of the epitympanum. So, Prof, when we finish, please tell us what you know about these various forms of mastoidectomies and may be employed, and it all depends on what you find. Sometimes you may have to do the mastoidectomy and then also reconstruct, do an ossiculoplasty or tympanoplasty. So it depends on what you find and how you, what the patient's hearing is and what methods you have to employ. So this study said that they realized that the surgical treatment of stages 2 and 3 retraction pockets were effective tools to prevent cholesteatoma formation. And the presence of retraction pockets with keratin accumulation and cholesteatoma formation are real predictors of poor prognosis in retraction pocket surgical treatment. In fact, yesterday we admitted a patient who has had subtotal petrosectomy on a second occasion after revision and is still come back with a recurrence of the cholesteatoma after a year. Well, so these are pictures I found of patients who have had or ears that reconstruction had been done. So the excision of the, after some kind of artichotomy, the cartilage is used to graft and then with fascial overrate, and that's how postoperatively the picture looks like. This is again another one where there's a retraction pocket, but this time there's granulation tissue, which might only be the tip of the iceberg with cholesteatoma beyond it, and there's erosion of bone. So this was how the picture looked like after reconstruction. I came across the glue tympanoplasty, where retraction pocket is sucked and then some kind of glue is applied. And here that study found that the same patient having had, or the same ear having had the glue tympanoplasty, that's how it looked like after surgery. Yeah, that there's some tympanosclerosis in addition. Then there's also the laser type of tympanoplasty. And the laser beam is said to contract the tympanic membrane by heating the collagen fibers, leading to their fusion and remodeling. And different wavelengths have been employed. They said the usual complications with these is microscopic and macroscopic perforations, carbonization, and coagulation that can happen. So as I come to an end, what I I wanted to just use these pictures to just to quiz myself. Like if I'm in the clinic and a patient comes and I examine and I find something like this, what would be my approach? I think that first of all, getting a good history will be very important. Whether the patient has hearing loss, whether the patient has been having some this recurrent otorrhea and what the discharge has been. And then on examination, if I find this with a retraction pocket which has this kind of scab over it, I'll try to clean it off if it's possible. If it's not possible, well, some patients I've seen when you try to clean so deeply, it's so difficult for them. But again, I'll try as much as I can. If I can peel off the scab, it's possible that beyond it will be cholesteatoma. And then I'll have the patient do an audiogram so that I can get a more objective kind of idea about the hearing or the level of hearing. And then the next stage might be to do, or would be to have an imaging done. So a CT scan to see how the state of the middle ear, the attic, the mastoid, how it looks like. And to the approach at treatment. So in this case, artichotomy will be useful. If the lesion is, there's a cholesteatoma which is going into the mastoid, then I could follow it where I could do a front to back mastoidectomy and then reconstruct the attic with cartilage. I can use cartilage, conchal cartilage or tragal cartilage to bridge the gap and cover it with fascia, temporalis fascia. But I may not really, depending on what I find, if looking at the tympanic membrane and the way it looks, I may not really aim at any significant tympanoplasty, because my fear is that you might tear it if you go peeling it off. This is another one which is more like Maringo staphylopexic. And in this case, I think my main approach would be to, if the hearing, even if the hearing is bad, but I can keep cleaning the ear, as long as there's no cholesteatoma visible, very obvious cholesteatoma, I may not want to do much, but rather be following the patient. And if I have to provide a hearing aid, I'll provide. If there is cholesteatoma, then no two ways, it has to be addressed. But to work on the tympanic membrane, I think it will be very, very risky, because the eustachian function, eustachian tube function is not likely to be very supportive in this case. So in conclusion, I'll say that retraction pockets occur where there's negative pressure, middle ear pressure or not. There might not be a negative middle ear pressure, but it's possible. Inflammation has been found to be a significant cause of the weakening of the tympanic membrane, making it susceptible to retraction pocket formation. Inflammation should be adequately prevented, or maybe also said to be treated, rather than adopting a wait and see approach. If we need to do an adenoidectomy, ventilation tube insertion or something like that, if we have to do it, we do it. And then various surgical options may be employed depending on the disease extension, the structures involved, and the patient's level of hearing. So these have been my references, from Scott Brown being the main one and other studies. Thank you very much.
Nice job. Yeah, there's a lot there. Yeah. That's good. So let's go back a little bit. There's a few photographs, if you don't mind. And we can talk from the beginning. Let me go back a little bit. We'll come back to those in a minute. Yeah, go back right there for a moment. So first of all, yeah, good, great job with all this. These are complicated patients in many ways, right? There's a lot going on. And so it's like you said, taking a good history. If they've had previous surgery or infections, always important to always ask about drainage, right? So, chronic otorrhea is what? If someone says oh, my ear's been draining for months and months and months, and then I put drops in, it goes away for a bit and it starts draining again. What does that immediately make you think of?
Well,
Cholesteatoma, right? So a chronically draining ear is a cholesteatoma till proven otherwise, right? So it's really important. And many times, depending on where they are in the stage of the disease, it's tough to really get a good look at the ear. Because many times if you maybe go forward one, Peter.
go.
Go forward in your present right there on the left side. Many
Okay.
times patients will present with that. That's what an oral polyp many times, right? Granulation tissue. It's been infected and inflamed. And so many times you can't even see the ear really well through all that inflammation. So sometimes you have to cool that off with some drops and steroid drops and antibiotic drops and bring them back. So first and foremost, yeah, it's really important to be able to get a good exam. And if you can't, you got to find out a way to do that. So you got to treat infection first, and then take a look at it. So like Peter was saying, there's a lot of things that cause changes in the drum that may not be iatrogenic. So certainly if they've had a traumatic perforation or someone's put they've had an infection, it causes spontaneous perforation. Someone's put a tube in the ear, all these different things that can be an issue. But for those folks that have never had that kind of issue, you always want to ask about things that change the middle ear pressure. And I agree, we don't completely understand all these things that are occurring in different patients from patient to patient, but I always ask every patient about their history of sinonasal issues, right? So everybody should be asked about allergies, chronic sinus infections, rhinitis, whether it's allergic or not, that can affect the mucosa, right, of the nose, the nasopharynx, the eustachian tube. And then as Peter mentioned, it's actually very interesting in kids. Certainly you can find gastric contents in the middle ear via the eustachian tube, but also I see a lot of reflux, a lot of patients here that have upper aerodigestive tract issues because of chronic laryngopharyngeal reflux. So people talk about the pressures of the ear, right? And Peter talked about this a little bit. And then people will treat these with, what they think could be eustachian tube dilations and structural things. Many times we've found that if you don't treat the underlying inflammation that's causing some inflammation, you can dilate all you want and do these different things, but it may not change it. So it's really important to address other things that could cause underlying inflammation of the soft tissues. And that could be if it's allergic, not allergic, is it infectious? Is it reflux? Is it caustic? Is it like gastric content exposure? And so I address those at the same time when I'm seeing these patients for the first time. Okay. As far as pressures go, I mostly see patients that complain of things when they change altitudes. And maybe you guys have seen that, right? They'll say, well, I got off of an airplane and all of a sudden I couldn't clear my ears and this type of thing. So, gases expand under areas of less atmospheric pressure, right? So they expand. And so people usually won't describe issues at higher altitudes. Usually when they're changing from a higher altitude to a lower altitude where atmosphere increases, gases compress, things get pushed in many times. And then people have a hard time ventilating against some of that negative pressure. At baseline, I don't really have a good way to measure pressure in someone's middle ear. And it's really a lot of these things that you mentioned, Peter, people have done some laboratory work in that to try to better understand middle ear pressures and mechanics, right? But I only typically see it, people will describe it if you guys have probably seen it in the clinic, they'll describe weather changes, right? Barometric pressure changes in the atmosphere might change some of that middle ear ventilation. So some people reliably will say, oh yeah, when there's a high pressure thing, my ear gets tight and full. And that could explain some of that gas compression law, the idea that gas is compressed, things get negative pressured versus expansion where the middle ear will naturally expand. And so some of that can be weather dependent. But regardless, it still speaks to potentially some of the underlying eustachian tube. Now, the structural changes that result from that in the drum are what's important. Okay, and you showed, if you can go back, Peter, a few slides. Let me tell you where I was going to have you stop. Keep going back. Yeah, keep going back a little bit more. You had a couple of really good pictures here. Keep going.
It must be the classification.
Maybe at the beginning. Yeah, right. Yeah, keep going back one more time.
So they,
Yeah, right here. Okay, this is good. Okay. So you're going to get all kinds of varieties of drum changes, right? So then it's really important to do pneumatic otoscopy, right? Can you determine, is it atelectatic, is it adhesive, or what? And many times, you know, depending on what you see, if you can get a good picture of the ear, if you just see some of these things that are retraction pockets that are clean. So for example, that far right picture, okay, where the solo picture on the right. Now, when you do an audiogram on that, certainly they're probably going to have a little bit of conductive loss, maybe a little mixed loss, right? Depending on their age. If the drum is slightly retracted and stuck down, maybe a little bit over the promontory, then maybe they have some adhesive there. You don't have to operate on all those. So what I look at is, the first you have to determine is it adhesive or atelectatic? Okay, number one. And that's assuming you can see everything, right? So if you've got a lot of debris and crust, like Peter talked about, and we'll go back to the quiz in a little bit. You've already said, okay, the ear is clean and there's no concern about cholesteatoma. So on that far right picture in that ear, I'm not concerned about cholesteatoma there, right? You see the little scutal defect above the lateral process of the malleus. The drum looks a little atelectatic, maybe even adhesive over the promontory. There's little speckled areas of tympanosclerosis there on the posterior side. You know, if you look at that ear and I do a tuning fork and get an audiogram, and they probably have a little bit of maybe a little mixed loss, and let's say that it's diagnosed with, you know, chronic otitis. The question I have is, can I salvage that ear or not from a middle ear ventilation or not? If the drum is already stuck down and it's showing adhesion, then there's no point in putting a tube in the ear, right? If it's atelectatic and the drum is starting to stick, I might say, well, we might want to improve the ventilation with a tube. But what you guys have probably seen in the clinic, what many times happens over chronic negative pressures, or whatever the process is, we think it's chronic negative pressure, the drum gets really thinned. It gets very atelectatic. And if you've ever tried to do this in an adult, where you make an incision in the drum and the whole thing is just paper thin. It's almost like you just cut through like parchment paper, really fine, like lens paper. Do you know what I'm talking about? They call it like cigarette paper or lens paper. It's very thin, and it almost like it just dissolves. So there's many times that even if it's not adhesive, if it's highly atelectatic, you still can't salvage it. You can't put a tube in the drum because it's not going to hold it. Okay. So you have to decide if that ear can you salvage the middle ear space? And if so, how would you do that? Well, if that's adhesive on that far right, which it probably is to a degree, we certainly know that now. Come to the bottom center picture. That's definitely chronic otitis media, probably adhesive, right? Look, you can see the round window niche. You can see the overhang, meringostapediopexy. It's really shrunk wrapped down over the promontory and over the long process of the malleus. Maybe in the anterior inferior quadrant where some of that tympanosclerosis is, you might see a little bit of ventilation of the middle ear. But there's nothing you're going to do to salvage that ear. Those soft tissues are adherent. But the real question is, do you need to operate on that ear? And I would argue you may not necessarily need to. In my experience, and I think in most people's experiences, that ear is pretty safe. What do I mean by that? Well, it's not likely to create skin invagination behind that. It's almost like it's shrunk wrapped down over everything to the point where it's sealed off. So for all intents and purposes, that ear is actually fairly safe. Now, the hearing is not very ideal, but you have to make a trade-off. You have to say, well, let's trade safety for function. Because to operate on that ear is no trivial thing. To go and operate on that ear that's in the bottom center, you would have to mostly trim away all of that drum that's been stuck down all those structures. Because mind you, you're going to probably rebuild that drum with fascia and cartilage. How difficult is it to see through cartilage in the clinic?
Very difficult.
Very difficult, right? You can't really see through it. So the challenge of that is, unless you are confident you can get every skin cell and every bit of tissue out before you rebuild laterally to that, if you don't feel confident in that, there's a high likelihood of iatrogenic cholesteatoma, right? Meaning you're going to take a safe ear and make it actually more an unsafe ear, meaning you're going to convert this to more of an ear that could be more at risk. Does that make sense?
Yes.
So in those circumstances, you have to make a really good decision about the risks and benefits. And I always have that. We've probably talked about that several times in talks before, where the idea of, you know, risk benefit. Okay, what's the risk of doing it versus not? What's the benefit of doing it versus not? You have to have that conversation with the patient. Now, if there's cholesteatoma, and I would even argue the drum on the left side, far bottom left corner, I can't quite tell if that's a perforation or not. Sometimes that could just be a deep retraction pocket. And from this view, it almost looks like it could be just a deep retraction pocket. But again, you know, Peter's using as an example of the, you know, the extent of the previous disease that could culminate in a perforation. What's more risky, a marginal tympanic membrane perforation or a central tympanic membrane perforation, and why?
The marginal tends to be more problematic because it tends to cause more of bone erosion and or to be associated with, it's more associated with cholesteatoma than the central perforations, which tend to be more of mucosal disease, not squamous.
And why is that? Anybody can answer that. And why would a marginal perforation theoretically be more risky or dangerous than a central perforation?
Well, I thought it still has to do with the retraction pocket idea going onto the bony margins and lytic enzymes, which would tend to be causing bony destruction associated with them. I don't know whether that's the explanation though.
Yeah, I mean, the thought is that, you know, if you have a marginal perforation, let's say, for example, that bottom left, right, it extends out to the annulus, right?
Yeah.
Well, the annulus is in contact with what? What's right there on the outer aspect of the annulus?
The bone.
Yeah, but that's the bone of what? The annulus is at the bottom of what?
The tympanic aspect of the, I know the tympanic aspect of the temporal bone is what forms where the ring will be. Is that what you mean?
Right. Well, what leads up to that annulus? The annulus is at the bottom of what? I'm sorry. I know I'm trying. It's kind of like guess what I'm thinking here. But the ear canal, right?
Okay.
So the ear canal ends at the tympanic membrane.
Yeah.
And so the ear canal is lined with skin, right? So if you have no impeding barrier or boundary between the bony ear canal and the middle ear, skin is sitting right there, constantly being shed from the ear canal skin, right? So if there's no, so the rationale is that it's almost like a continuous part of the ear canal right into the middle ear. So if you have if you have a big perforation there, the idea is that skin can just migrate right in. Does that make sense?
Yes.
Versus having a perforation that's in the center, you still have part of the drum that sits at the annulus, where that could create theoretically a bit of a barrier of migration of skin from the medial depths of the ear canal into the middle ear. Does that make sense?
Yes.
So that's part and part why people think that a marginal perforation would be more dangerous than a central perforation. Now, albeit many people that have marginal perfs I've seen Oftentimes, if you have subtotal perforation, that's actually safe. Okay, so people will say, well, why is a subtotal perforation safe? That's all the way out to the margin. Well, it's because the entire drum is gone. You've almost exteriorized the whole ear. There's no place for it to trap skin, right? But if you had like a small marginal perforation, usually in the anterior inferior quadrant over the opening of the eustachian tube, that's a dangerous area because skin can migrate through the hole and then get trapped under the drum. But if you have no drum in a subtotal, then there's no place for the skin to hide because it's really been exteriorized. Okay. So yeah, so this migration is great. Now, Peter, go to the next slide, if you don't mind. There. Now, when you see these defects, again, this carries over what we were just talking about is many times these retraction pockets or scutal defects like this, if you can keep them clean like these are, these may not necessarily be surgical either. Okay, so just because you see that you've got these variable sizes of defect above the lateral process into the scutum, okay, doesn't necessarily mean you have to operate on these folks, because if you look at it and they can keep it clean, and we use a lot of vinegar and water rinses in the ear here. If you can keep those retraction pockets from obtaining or retaining dead skin, squamous debris, then you don't necessarily need to operate on those folks. You can actually just keep those clean and watch them in the clinic. Okay. So, but the key is when you're in the clinic and you see those, and they oftentimes will have a crust under there. And if they are retaining skin, like the paper you presented, then that's likely that they're going to attain a cholesteatoma. Now, what space is that right there where that skin's going to go up into? What do you call that area between the scutum that's partially eroded here and the neck and head of the malleus? What's that space called?
Prosthetic space.
Prosthetic space. And you can see why most cholesteatomas will start there, right? Because that retraction will get pulled up into that pars flacida, 2 layers get pulled up right into that space. And then that's when you start trapping skin in the epitympanum. But in certain circumstances like this, sometimes if it's eroded and it's exteriorized and you keep it clean, that the matrix of the skin, well, if you keep that clean, it may not migrate any further. So oftentimes in these situations, you can wash it. If people can keep them clean, you can avoid surgery. Does that make sense?
Yes.
Yeah. Okay. So keep going here. Let's go up to your quiz here for just a minute.
The quiz.
Sorry, I don't mean to take all the time and be chatting you guys up here, but yeah. So there, okay. So first of all, I've never used the glue. I don't have any experience with just glue tympanoplasties. Here, in this circumstance on the left side, you'll have done pneumatic otoscopy, right? To see, are you pulling that little retraction up? But that's a pretty deep retraction there, right? And so that probably would need repair if you can't keep that clean. And so I've never done glue there. I would lift the drum and I would repair that formally with probably some cartilage. And then the real question is what are the, I agree with the imaging. If there's a concern there, obviously you want to see what else is in the depths. And then you have to look at the accular chain, right? Because many times, do you repair the accular chain at the same time or not? Yeah, go to your next slide. Let's see here. Right there. Okay. So the key there, and you said it, is you've got this that's a concerning find, that posterior superior deep retraction, right? And then you've got it looks like a debris you got like a scutal crust, right? Those 2 things are probably connected. So you're right to clean the crust. You're going to look for that scutal defect. Chances are you lift that off, I'll bet you're going to find frank keratin debris underneath that thing. And then of course that warrants a procedure there. All right.
Yeah.
And CT scan, definitely important so that you are looking at the extent of that. Is that extending into now where likely is that if you have disease in that area, where is that going to go? Is that going to go anterior epitympanum? Is that going to go down into the mesotympanum? Is that going to go into the posterior epitympanum toward the mastoid antrum? If you had to guess, what you might see on a CT. What do you guys think?
Slightly.
I think it's going into the epitympanum.
And then where would it go from there typically?
You would go posteriorly towards the antrum.
That's right. That's right. So, based on some of the ligaments there, oftentimes when disease starts up high there or kind of in the posterior superior quadrant, it's going to be restricted by some of the ligaments, malleolar ligaments oftentimes, unless it's been eroded through it. And it'll kind of work its way back toward the mastoid antrum. So on a CT, you might find that there's soft tissue density into the mastoid antrum. Okay. If disease starts usually in the anterior epitympanum, sometimes you'll see that in front of the malleus handle or the lateral process. The anatomy there will almost push it down and it'll work toward the promontory towards sinus tympani. Do you know where sinus tympani is?
Yes, bro.
So it's not always going to be that way, but sometimes you can kind of predict like where you might find the disease. Okay. Yeah, so here you're absolutely right. Adicotomy. I usually take tragal cartilage when I can. Sometimes I'll use Simba cartilage. Tragal cartilage is nice because it has really robust perichondrium, which is, I'll peel that off and I'll use that to kind of drape up the lateral part of the scutum. So if this is the cartilage, you can see my hands. Like this is the tragal cartilage. I'll peel off a little bit of the perichondrium like this. Okay. I'll leave perichondrium on the back side, but then this side is up. And then I could lay the cartilage in. This would be on the middle inside of the ear, on the outside of the ear. And then this gets draped up the scutum. So it kind of holds it. I use the perichondrium to kind of hold the graft in place along the scutum. And it's really nice. And then you lay that in and contour that in next to the tympanic ring. And it really, cartilage is wonderful. I think it works out really well. And I don't know, Peter, what you presented with the data there. I think it depends on the size of the cartilage and where it's located. Will dictate how much it may impact the ear in terms of conductive hearing loss. But you have to tell patients that they're going to experience maybe a little bit of persistent conductive loss because you're using tissues that are much less compliant. Does that make sense?
Yeah.
So, but it's so important because otherwise you'll get retractions there. Okay, so let's look at your next one. Now here, I think as you said it, is honestly, you have to talk about what the goals of with the patient are. Here, this is a pretty clean looking ear. I can't quite see behind posteriorly down below near that annulus there, but I definitely see the round window niche, right?
Yeah.
The rest of the ear looks pretty clean. Anterior, inferior, and anterior superior quadrants. But my guess is putting a tube in this ear, what do you guys think? Do you think putting a tube in this ear will solve that problem? No, right? So there, I would say that if that is clean, you could watch that. You could. Depends on what the goals are of the patient and what the audio shows. Okay. But again, this is taking a situation where that ear is probably pretty safe. And you have to determine, okay, is it worth performing surgery? Because you're going to have to lay cartilage over that area likely. And you have to be really sure that you've got all the skin out over that round window niche over it. See, because it looks like it's draped over the stapedius tendon there. And then just above the stapedius tendon, as it's going back toward the mastoid antrum, you have to make sure that that's clear as well, right? Yes, so if it's clean and they can keep it clean with hygiene and the hearing loss is minimal, you could watch that ear for a while. So do you see what I'm getting at? Is sometimes it just depends on what the goals are. Okay. But I think the keys on these, again, there's a lot going on with these kinds of folks. So eustachian tube dysfunction at the outset, you have to look at what that's causing. The other thing that Peter mentioned, which is really important, is if you have a patient with a unilateral effusion, not infection, but effusion, you need to scope them. You got to look at the nasopharynx. Okay. Really important. Make sure they don't have a nasopharyngeal tumor. or finding, or sinonasal tumor. The other thing, what else would you think about if it looks like there's fluid in the middle ear and you look in the back and you're like, well, there's nothing there. This could be just a middle ear effusion from eustachian tube dysfunction. What else could it be? If it's not infected.
A mass in the nasopharynx.
If it's not a mass on the nasopharynx, let's say you see fluid behind the drum and
Prof, I read about the patulous eustachian tube. I don't know whether that's
if it's patulous, would you think there'd be fluid in the middle ear? Patulous
No.
means that the eustachian tube is constantly open, right?
yes.
Those folks they'll hear their own breath in their ear. And it's fascinating. When you look in their drum, look at their ear under the microscope, when they breathe, the drum is moving with their breath. So every breath is they're getting positive pressure insufflation of their drum, middle ear, and it's pushing the drum out. Those are well ventilated middle ears. They're not going to usually accumulate any kind of negative pressure force and pull middle ear fluid in. What if you see?
What about a perilimb fistula?
No, there's such little amounts. There's only microliters of fluid in the middle ear or the inner ear. Yeah, good thought, but no. So
Effect.
why okay, what would that give you?
Well, CSF leaking into
The CSF leak, right? People forget about that. The brain lives right there. So I see, unfortunately, a lot of patients come to me and the classic story is, oh yeah, I several months ago, my ear became full. My ENT doc told me that I have fluid in the ear. They put a tube in my ear and now the ear won't stop draining clear fluid. And they're coming to see me.
Wow.
And so I look in there and I see clear fluid pumping out of a tube in the ear. And I'm like, oh no. So the first thing I have to do is pull the tube. You got to pull the tube because now that person's at a risk for meningitis. You got to get scans, and invariably they've got a big skull-base defect, tegmen tympani or tegmen mastoid EM defect, plus or minus encephalocele, right?
Okay.
And we're seeing a lot of that here in the States because there's a lot of obesity in the United States.
Okay.
And obesity causes increased intracranial pressure, benign intracranial hypertension.
Yeah,
And that leads to encephalocele and or leak. So when you see fluid in the ear, don't always immediately think, oh, that's eustachian tube dysfunction. We got to get a tube in. Sometimes if you look at the middle ear, if the fluid's yellowish, has an amber color to it, that could tip you off its eustachian tube. But if it's clear, if it's like a clear air fluid level in there, be on the lookout that could be a CSF leak. Okay. But yeah, good topic, Peter. This is bread and butter stuff. You guys will see a lot of drum changes, so you have to really look closely at it. But do a good history on sinonasal reflux, laryngopharyngeal reflux, allergic, non-allergic rhinitis, history of chronic sinus disease, inflammatory disorders, right? And then look at their changes in their altitudes. Look at, are they sensitive to pressure changes, right? Do they travel a lot, air travel? Are they, changing altitudes? Those types of things. So there's a lot going on, and be very specific about what you see in the drum. Do a really good exam with positive negative pressure pneumatoscopy. Characterize it adhesive, atelectatic, plus or minus cholesteatoma. So there's a lot to unpack in these patients. Okay. But good stuff. Sorry, I don't want to keep you guys. I know you got stuff to get to, but good job, Peter.
Thank you so much for.
Yeah, guys. Well, have a nice Friday and drink a lot of water. Stay hydrated.
Yes,
Thank you.
It's only 2 degrees here. What's the temp there? What's the temp in?
What's the
28
Celsius?
I don't know what's in Fahrenheit.
28 Celsius. Hang on a minute. Let me figure that out.
I think it's about 90.
28. Oh, that's 82 degrees Fahrenheit. That's beautiful. That's warm.
It doesn't feel beautiful. It feels.
That's
really
warm.
hot.
28 is 82.4 Fahrenheit. That's warm.
Yeah.
Yeah, very nice. All right, guys. Well, good to see you.
Yes,
All
for
right.
We'll see you next week.
Okay,
thank
bye.
you. Bye.
Bye.
Nice job.
Stop recording.